everyone. Our lecture today is about extraction versus non-extraction treatment. In this series, we're looking at the treatment planning in orthodontics. So we started with the space analysis, orthodontic indices, and today extraction versus non-extraction. And next lecture, we will now get all this knowledge to do the treatment planning in orthodontics. So extraction versus non-extraction is an endless dilemma. It's been there forever, whether we should take teeth or not. So Angel, when he started doing his orthodontic treatment, he was strongly against any extraction of the teeth. He believed that the patient should have a 32 teeth functioning in the mouth. And he based that on Wolff's law of bone expansion. So he believed that the teeth can cause the bone to expand to accommodate the crowding that is there. So he believed that all the teeth, even the wisdom, should be there. Angel was very powerful at the time, so no one can argue with Angel. But after Angel passed away, a tweet came up and say, okay, I looked back into the cases and I found that he was not happy with the stability. He found that the non-extraction treatment is unstable, and he recommended extraction of four premolars, and he said that the occlusion is now much more stable. However, this is not a kind of properly designed study. It's just an observation tweet. He did the extraction. Now he said, okay, this is more stable results. Independent work from Big in Australia. He said that a non-extraction treatment is not stable, and he advised for the extraction treatment. So now, in the beginning, in the 1930s, there was a huge non-extraction treatment. Then after Tweed's work in the 1940s, up to the mid-80s and the early 90s, there was a huge extraction swing. Most of the cases were treated with extraction. But then after the extraction's been done all the time, and you see and you do follow-up of the cases, and you realize that, as we're going to see later, that the extraction will not result in a more stable results. So the orthodontist or the orthodontic world swing back into the non-extraction treatment. So now the most common of the cases are treated with non-extraction. So why do we take out teeth? Why do we have to do extraction? These are kind of many reasons that we have to do. The first one, to make space within the arch to relieve crowding, just to need to create space for alignment. To avoid, again, excessive proclination of the teeth, we're going to see later. Reduce the fullness of the lip to improve the patient profile. More stable results, we're going to see about that of the evidence. Pathological reason, for example, if you have a badly destructed 6 and you take it out and you do space closure, to reduce the overjet and overbite, and this is understandable. Sometimes encourage consideration, especially in the vertical dimension, to correct the buccal segment relationship. Camouflage treatment to camouflage class 2 or class 3, in which if you don't even have crowding, you just need to camouflage the jaws. And decompensation if the patient want to go for surgery, and sometimes as an interceptive treatment, especially when the canine has no space and you go for the extraction of premolars to allow the canines to erupt. So for that, we need to know how we can provide space. So last time we studied how to calculate the space requirement. Now we need to know how we can provide space to treat the malocclusion. The first method is extraction. So basically, as you can see here, one of the premolars were extracted to accommodate the crowded lower labial segment. So extraction is the method of providing space. Transverse arch expansion. So if you look at the patient here, what you do is to correct this crossbite, we do expansion of the arch, as you can see here. According to the Royal London Space Analysis, each 1 millimeter of increase in the intermolar width will give us a 0.5 millimeter of space, which is good. However, you need to know that you don't want to do an excessive expansion because when you do expansion, you are going into the space of the cheeks, because the teeth are in a state of equilibrium between the tongue and the lips and cheek. So if I push these upper premolars out and doing expansion, I'm invading the cheek space, and they will try to constrict the arch again. And the same happen if you do expansion, and we're going to see later proclination of the incisors. The lip will try to retrocline them back in again. So expansion should not be done excessively. And in the next lecture, we're going to talk about treatment planning. We're going to discuss how stable is this expansion and how much can we do with this expansion. Anteroposterior expansion, which is basically a proclination of the upper incisors. So how much we can procline these incisors. Proclination is a very efficient way of providing space, because each 1 millimeter of proclination will give you 2 millimeter of space. However, again, there's two issues with proclination. The first one is stability. Again, when you do proclination, you are invading, especially in the lower arch, the lower lip zone, which means that the lower lip will try to push the lower incisors back in again and causing relapse. The other thing is about the proclination is the profile. How much when you procline the incisors, is that going to affect the patient's profile? Because when you do proclination, you push the lips forward. And this is something we need to consider. Again, all of this will be discussed with evidence next lecture to decide which one we should choose. But we need at the moment to know advantages and disadvantages of each method and how much space it gives us. As we can see here, that we can provide space by pure proclination, and if you do proclination of more than 2 millimeter, then bonded, especially in the lower arch, bonded retainer is required. But just need to make sure that you don't excessively procline the incisors. Again, as we said, not to affect the patient profile, not to cause damage to the periodontium. And as you can see, this is from Handbook of Orthodontics textbook. You see how much proclination is being done to accommodate this canine. That's a lot of proclination. Teeth are not, any force now will be almost perpendicular to the long axis of the tooth, which is not what we want. The other option to provide space is to do distalization by moving the molars posteriorly. Now it's become very popular, especially as the benefit system from William Benedict and other people who are doing now TADs, and they do distalization of the molars. Now before that we used to use nudger appliance, pendulum, headgear, in which the maximum we can do distalization is 3.5 millimeter. 7s should have not been erupted yet, or if they erupted you should do extraction because that will be easier to do distalization. However, nowadays with the TADs you can get more distalization, however that will result in impaction of the molars. Still, it's a good method of providing space. Interproximal reduction is another method of providing space, so there's different methods, and we'll cover that in detail. However, for now, the DNI can do an interproximal reduction to create space. Don't forget that the maximum you can take for the interproximal reduction is 0.3 millimeter from each contact point of a tooth, which means from each contact point between two teeth you can get 0.7 millimeter of space. Now, when you do stripping, you need to look at the anatomy of the teeth, because the teeth that provide with the most space are triangular teeth. After that is the parallel-sided teeth, and the least one and the worst for interproximal reduction are parallel shape, which his teeth are like this. So in the clinic, please, when you decide to do interproximal reduction, take a look on the anatomy of the teeth, because you don't have to rush and do the extraction, stripping for a tooth like this, because you're not going to get a lot of space. So now, extraction or non-extraction treatment. That all was an introduction for the lecture. So there is a claimed advantages of the non-extraction treatment. People who support the non-extraction say, okay, this is less trauma to the child, which makes sense. If you don't do extraction, no anesthesia, no any kind of experience of the extraction. Ease of treatment, because you're not going to have an extraction space. Consumer demand, because patients now, they ask for a non-treatment. Parents, they don't like to take the teeth out for their kids, so it's a demand. Shorter treatment duration, it is give you a fullness of the profile, so that you look younger. It's less iatrogenic effect on the TMJ, that extraction can do retraction, as we're going to see later, retraction of the incisors, and can cause TMD. Less impact on the vertical dimension. It's claimed that extraction will do reduction on the skeletal vertical dimension and effect on the smile that will cause narrow buccal corridor. So for these ones now, we're going to see the evidence. These are claims. These are opinions. So where is the evidence from these claims? So again, the people who support extraction, they will see that it's controllable outcome. It's controlled better than if you do non-extraction treatment. It improves stability. That's why actually extraction treatment is into use. It reduces the protrusiveness of the profile. So while you're doing extraction, you don't do a protrusion of the incisors, and you don't do a protrusive of the profile, and you don't do any gingival recession. Again, we need to investigate the evidence, and here we go. We need to see the evidence with or without extraction. So which one is better? Start with the first one, which is the patient profile. So the claims are that if you do extraction, that will result in more retraction of the incisors, which would result in a retrusive profile, meaning that the upper and lower lip will be retrusive in position compared to the patients who are treated with non-extraction because you give support to the soft tissue. What is the evidence? This is a systematic review in which they look at the aesthetic perception of changes in the facial profile resulting from orthodontic treatment with extraction of premolars. So basically what they did is they looked at the study that they asked for patients' perspection of their profile after they have done extraction of 4 premolars. So the author conducted a systematic review to assess changes in the patient's facial profile resulting from orthodontic treatment with and without extraction of premolars and to identify if there is any cephalometric parameter that can assist in decision making. There is no significant difference between the groups in the term of aesthetic outcome. So basically, the perception of the profile, it is not related how much the lips are retracted. It's just related to the perception. You do extraction or non-extraction, the perception of the patient about the profile is the same, which means that the patient does not feel that their profile after the extraction are retrusive, or they don't feel that extraction will worsen their profile. However, this study did not come up with any cephalometric parameter. However, the initial lip protrusion can help you to decide regarding a borderline cases, meaning if you have a patient with a protrusive profile, you definitely don't want to go for extraction, non-extraction treatment, because to get space, you will push the teeth even more anteriorly, making the profile look worse. All I need to do at this stage is to do an extraction treatment. All right, another systematic review, but this one, they looked at the people with bimaxillary protrusion with the extraction of premolar. You know, when you have a patient with bimaxillary protrusion, all what you want to happen is that you want to retract the teeth. Hopefully, the lips will retract and you will improve the bimaxillary protrusion. However, so what they did is they searched and conducted a clinical trial that assessed the cephalometric perioral soft tissue changes in patient affected by bimaxillary protrusion and treated with extraction. So what did they found? The lip competency improved following the extraction of the 4 premolar, and improvement is predictable. So definitely the patient will have competent lips. However, the changes are small and they don't detrimentally modify the patient's profile. A dished-in profile is not expected. Individual variation, however, is in response is large. So let's stop here. So we do extraction, we retract the incisors, lips become competent, but then the amount of the retraction will not dramatically affect the profile. So the patient will not have a dished-in profile, as we could expect. So the claims that the extraction caused dishing in of the profile is not true. So let's go and do extraction, guys. It's not going to affect the patient's profile. Again, this is not completely true because there is a huge individual variation in the response. And later we're going to see why is this a huge variation. But we can know now at the moment that extraction does not affect the perception of the patient about having a nicer smile or better smile. Extraction does not cause any dished-in profile, and that's an evidence-based thing. So the claims against extraction so far is not true. And this is another study in which they looked at the soft tissue changes following extraction and non-extraction to see how many millimeter when you do extraction you are expecting the profile to change. And what they found is that when you do extraction, the lower lip you can do retrusive up to 1.9 millimeter, while in the upper lip you can do that up to 4.9 millimeter. However, these numbers should be very careful when we read it because it's different between patients. That's an average value or the maximum value, sorry. So what they concluded that with fixed appliance treatment with tooth extraction, it might be associated with different in soft tissue profile compared to the non-extraction treatment. However, the response is variable. We can't come up with amount of retraction, that kind of ratio. And they said that the factor that it depends on how much we retract, how much the soft tissue is affected, patient's age. So the older the patient, the more flaccid the muscle, the more will be affected by the retraction, and on the opposite way by proclination. So if a patient has a protrusive profile and he is old, you can do even more proclination. You tend to do extraction, and the opposite is if it is the other way around. And also they found that it depends on the extraction protocol. So if you do extracting of the fives, you get less space on the anterior teeth. While if you do extraction of the fours, you get more space, more retraction, kind of more effect. It depends on the amount of the upper incisor retraction during the treatment. So how much you reinforce your anchorage and how much you retract, which teeth you're going to extract, all of that affect the response. So again, soft tissue variation is there. So to summarize this paper, the maximum we get with the retraction is 2 millimeter in the mandible, 4 millimeter, that's a maximum, and there's a huge variation. The cause of the variation could be, or the predictor of this variation, patient's age, extraction protocol, amount of the retraction. The quality of evidence, however, for these studies are really weak. So we don't have a conclusive result so far about how much the lip will retract when we do the extraction. All what we know so far, it will not affect the perspective of the patient about the aesthetic profile. If we have a bimaxillary profile patient, extraction will result in retraction, but it will not result in a dished-in profile. I like this paper because it helped me to understand the effect of the extraction of the soft tissue. What they did is, they look back, it's a retrospective study, at the pre-treatment, post-treatment lateral cephalogram of patients who are 61 growing patient, class 2, aged between 11 and 18 years old, class 2 division 1, 39 patient, 22, class 2 division 2. All of them were treated by extraction of upper fours, not lower, only upper fours, and they did retraction of the incisors to correct the overjet. So what they found is that the nasolabial angle on average increased by a mean of 3.6. However, they said there is a huge variation in the response to the amount of the changes in the nasolabial angle. It's not the same. People, they have more increase in the nasolabial angle. The other patients, they don't have any change in the nasolabial angle. So there's a huge difference. But the thing is, they said there is no correlation with the incisors AB changes. So basically, you will think if I have a retraction of the upper incisors by 5 millimeter, then this will definitely result in more lip retraction than if I retract the upper incisors by only 3 millimeter. That makes sense because I'm retracting the upper incisors more, so I should get more retraction of the lips and more increase in the nasolabial angle, but this is not the case. The strongest association for changes in the nasolabial angle were seen with the inherent soft tissue factor, such as a pre-treatment lip thickness and lip curvature depth. And this is here kind of give us a summary of the situation. It depends on the soft tissue rather than on the AB position. So if, for example, you have a patient and you retracted the upper incisors by 5 millimeter, and this patient's with a thick lip, the lips will not move. You will not result in a dished-in profile. You do the same movement, 5 millimeter retraction of the upper incisors, in a patient with a thin lip, the lips will move and you might result in a dished-in profile. So dishing in of the profile, it's more of the type of the soft tissue rather than the AB position of the teeth. Having said that, that doesn't mean that I will go and say, okay, extraction does not affect the patient's profile. Let's do it for all patients. And you get a patient with a thin soft tissue and you do the extraction and retraction. That will result in, again, thin retrusive profile. So to summarize the extraction and the patient's profile and retrusiveness, it is not, the perception of the patient is the same. They said, okay, whether you do extraction or not, the effect is the same on the patient. They don't see any difference. If you have a patient with bimaxillary protrusion and you do extraction, you don't get a retraction of the lips as much as you do the retraction of the incisors, and this is expected. So what decide how much the lip will move when you retract the upper incisors? Number one, the thickness of the lip, the curvature of the lip. So the thicker the lip, the less it will be affected by the retraction. The age of the patient, the older the patient, the more it will be affected by an extraction decision. The younger one, it has a good musculature, the lips, they hold themselves. To a lesser extent, the extraction protocol, how you achieve the space closure that you do. And finally, and definitely, is the anteroposterior position of the incisors. How is that? If we have patients with thin lips, both of them are the same. If you retract the incisors 5 millimeter, you will get a lip retraction. If you, in the other patient, you do a retraction of the upper incisors of 7 millimeter, you get more a retraction of the lip. So yeah, AB position has an effect, but the most important effect is the soft tissue factor. So what about how much we plan now? If we're gonna do planning, how much, if we retract the incisor, how much we get retraction? I like this paper by Baquet. He said, on average, if you retract by 1.4, you get 5 millimeter of retraction, which means 1/3 of the distance of retraction. So if you retract by 3 millimeter of the upper incisors, the upper lip will move by 1 millimeter. And so basically, the more you retract, the more you will get the retraction of the lips. However, this one is unpredictable and it depends on the patient's profile. However, these numbers are not fixed because that's different between patient to patient. This is according only to this study. And it's just an estimate for you in the clinic. However, if you go and read textbook of Profit, and that will be discussed in the next lecture about treatment planning, he mentioned that according to the evidence, if you retract its upper incisors by 3 millimeter, you get 2 millimeter of lips retraction. So again, the range is between 1/3 to 2/3 of the movement. It depends on the soft tissue of the patient. The thicker the lips, the less retraction you get. The thinner the lip, more effect you get. So that's important to understand. And regarding the retraction, something as well we need to know, that when you do retraction, if the lips were incompetent before the retraction, then you do the retraction, then the lips become competent, they start touching each other. Here, where the lips stop moving posteriorly, because now they kind of hold each other. They don't need the teeth to hold them. This is one reason why if we, in bimaxillary proclination patient, we do extraction and retraction, we don't get as much retraction of the lips as retraction of the incisors. What about the smile analysis? If there's a claim that if you do extraction, you will ruin the patient's smile, especially the buccal corridor, because you constrict the arch. A systematic review to look at the clinical effectiveness of orthodontic treatment on a smile aesthetic, meaning extraction or non-extraction. The aim of this study is systematic review to identify how different types of orthodontic intervention affect the aesthetic of the smile any time after orthodontic treatment, meaning that different, when you say different intervention, that extraction, non-extraction, different modality of treatment. There was slight evidence that extraction do not affect the smile width and the buccal corridor. And this was the main concern regarding extraction, because when you do extraction, you constrict the arch, so the width of the smile will be affected, the buccal corridor will be bigger. So there is no evidence to support this claim. So extraction, again, come up as that they don't do any of these problems. The rest of them regarding the smile arc and midlines, there is not enough evidence to say whether or not extraction can cause a flattening of the smile arc. However, the most important that we need to know about is the buccal corridor and the smile width, and we know from the evidence that this will not be caused by the extraction. So the smile, again, extraction caused no problem with the extraction and the buccal corridor. No problem with the profile so far. What about vertical dimension? There is a claim that extraction of the premolars will deepen the bite and tip the lower incisors lingually and reduce the vertical skeletal dimension. Vertical skeletal, not only dental relationship. And here it comes this systematic review, which basically they looked and assessed the evidence of the effect of orthodontic treatment with 4 premolar extraction on the skeletal vertical dimension of the face compared with a non-extraction treatment. Again, as expected, they found no evidence to support these claims. Extraction does not result in reduce vertical skeletal relationship. That's very important, because we know that extraction will help us to improve the overbite, will deepen the bite, but here we're talking about the skeletal relationship because of the auto-rotation of the mandible. Again, there is another claim that if you do extraction of the teeth, you will do retract them to correct, for example, the overjet or bimaxillary proclination. Over retraction of the incisors during space closure will result in the displacement of the mandible posteriorly, which will cause temporomandibular joint dysfunction. Is this true? Unfortunately, fortunately, there is no evidence to claim this is true. There's no evidence that orthodontic treatment will result in any temporomandibular joint dysfunction syndromes. On the other hand, okay, if that is true, what about if a patient has a malocclusion? If we treat him, does that cure TMD? Well, again, there is no evidence to support these claims either. So you can, and it's not justified to start an orthodontic treatment just to treat signs and symptoms of temporomandibular joint dysfunction. Cochrane Library by Luther et al. It came up first at 2010 and then another one in 2016, and they said, okay, there is no evidence that orthodontic treatment can prevent or relieve the symptoms of temporomandibular joint dysfunction, so there's no relationship. However, this one was withdrawn, this Cochrane Library review, and the reason of withdrawal is that they said, okay, we need to take it back, we need to review the papers that is published in this one and post it back in again, but so far nothing has been done. It's just withdrawn from the Cochrane Library. So now, do we have any evidence that orthodontic treatment, especially extraction, can cause temporomandibular joint dysfunction? Answer is no. Do we have any evidence that patient has a malocclusion and we do treatment for them will improve the temporomandibular joint dysfunction? Answer is no, according to the evidence that we have so far. However, it's important to notice if the patient have any symptom of TMD before you start orthodontic treatment, because you need to know if these symptoms developed after the treatment or not. And here there's something to make it clear. So far, we don't have an evidence to say that orthodontic treatment can cause a problem. At the same time, we don't have an evidence to say that treating the patient will relieve any symptoms. But does that mean that it is not there? We don't have an evidence to prove it, but it could be there. It could be, but it's unlikely. And here again, I will come back to something we call it the individual variation. Some people, they react in different way. When we say evidence, we say about the average response of the population. And that's why I want you to focus when you examine the patient to record any TMD present, to know if these symptoms developed after the treatment or not. So far, extraction, all the claims against extraction are not true. Profile, smile, vertical dimension, TMD, no, you can go with extraction safely. So now what's about the claims with the extraction, which is gum recession? Because if you don't want to go do extraction, then you need to procline the incisors and expand the arches. So what is the evidence that expansion or proclination can result in gum recession? Artin in 1982, he examined the periodontal status of mandibular incisors following excessive proclination, and he found that if you procline more than 10 degrees or more than 4 millimeter movement of the incisal edge, then you are inviting a gum recession and dehiscence. So you don't do proclination more than 10 degrees. But that's again one study. So what about the systematic reviews? Another systematic review by Aziz et al. And he looked to the studies that compared the effect of the periodontium, the proclination on the periodontium. And what he found is very important, that there is no association between appliance-induced labial movement to the mandibular incisors and gingival recession. The factor that may lead to gingival recession after orthodontic treatment or orthodontic tipping or translation movement were identified as reduced thickness of the free gingival margin, which is the keratinized gingiva, the one we call a thin biotype. If you examine it, there is a reduced thickness of this attached mucosa that is necessary for fighting against plaque-induced gingivitis or even proclination. Narrow mandibular symphysis, inadequate plaque control, and aggressive toothbrushing would make sense. So if a patient have aggressive toothbrushing, gum recession will result. If a patient has a poor control of the plaque, then you will have a gum recession. So when you decide to procline incisors, you need to investigate the thickness of the soft tissue, the amount of the symphysis that is there, how is the patient plaque control, and give him the right instruction about the brushing. Another study in which they look, that's done in Sweden, it's for 5 years study, in Switzerland and Bern. They looked at the proclination of the lower incisors, and they said the proclination of the mandibular incisors did not increase the risk of development of gingival recession during 5 years observation in comparison to a non-proclination of the teeth. So they looked at the patients with proclination, no proclination, and they found, okay, there is no difference in the gum recession between the two groups. Again, that's even more one. That's a 20 years follow-up for patients who are adolescent, and they came up to the conclusion that proclination of the lower incisors will not result in a gum recession. So, well, that's good. Why not? Why to do extraction? Let's go and procline the incisors. Well, that's not true. Well, excessive proclination might result in gum recession. When you do proclination of the lower incisors, I would strongly recommend to look at the gingival thickness, the amount of the attached mucosa, patient's oral hygiene, the amount of the symphysis, if it's narrow or not, because that will affect our recession or not, as it's mentioned in the previous paper. And again, the reason for the proclination, again, it's stability. So the claims with the extraction, and that's why extraction treatment has started, is simply because it's more stable. So let's extract, and that will not worry about stability after. Is that true? Let's see. Little, in 1983, he did a retrospective study that patient treated with extraction of lower fours, and he investigated the lower incisor crowding after 10 years. And he found that the long-term alignment is variable and unpredictable. An arch dimension of width and length typically decrease after retention, where crowding increase. So if you do expansion, so if you don't do any expansion, regardless how you're going to do the treatment, the arch will collapse. So for that reason, in spite of treatment maintenance of the initial intercanine width, treatment expansion or constriction, they will still have relapse. So even if you maintain the intercanine width, even if you did not do any expansion, you do extraction, still you will get relapse, because with days, this intercanine width will become a little bit narrower, incorporating and introducing more relapse. So can we do extraction to prove stability? The answer is no. However, it seems sensible to minimize the treatment expansion, but maintenance of the original intercanine width is certainly no guarantee of stability. So okay, do expansion, don't do excessive expansion, because the more they expand, you get more relapse. But at the same time, don't go and do extraction just for a stability reason, because that's not true. And here's an interesting paper. They looked at the different methods of retention regime. So the whole idea and the whole plan was to investigate the different retention regime. And they did that over two groups, extraction and non-extraction patient. And what they found is, whether you do extraction or a non-extraction treatment, if you are using one of these three retention regime, there is no difference of the end result. Okay, wait a second. So the stability is the same, because anyway, you're gonna use a retention. Because now, even if you do extraction treatment, you can't send your patient without a retainer. He has to commit to a retainer, because retention, as we covered in the retention and relapse lecture, it's multifactorial. He will have relapse at some point, so we have to provide him with a retainer. So if we're gonna provide him with a retainer anyway, that means that whether we do extraction or a non-extraction treatment, the result will be the same according to this paper. So it's not justified to say I'm gonna go for extraction treatment just to reinforce stability. So let's summarize everything. Patient's profile. Well, we know that if we do extraction and retraction, the movement of the lip is highly variable between patients. This response of lip movement depends on the soft tissue of the patient rather than how much we retract these upper incisors. The thicker the lip, the less they will react to the incisor retraction. The thinner the lip, the more they will react to the incisor retraction. Age of the patient has an influence as well as of the patient's profile. The older the patient, the more they will be affected by extraction decision. However, all the evidence suggests that extraction will not affect the perception of the attractiveness of the smile. Patient, they don't see that the extraction will result in a retrusive, not nice profile. Smile width, there is no evidence to support that extraction will result in increase in the buccal corridor or reduction in the smile width. Vertical dimension, there's no evidence that extraction will result in reduction in the skeletal vertical dimension. TMD, there's no evidence to suggest that extraction will result in TMD problem, rather than starting the treatment will result in development of TMD. Gum recession, again, if you do proclination of the lower incisors, the recession will more dependent on the thickness of the attached mucosa, the oral hygiene of the patient, and how he brushes his teeth, aggressive or not, rather than how much you procline your lower incisors. And we saw that after 5 years, there's no difference, and even after 20 years. Stability of the treatment, again, the extraction was claimed to increase stability. However, relapse is a multifactorial issue. There's more one reason to cause relapse, but there's no difference if you do extraction, non-extraction. Anyway, you have to go for retainer, and if the patient is wearing the retainer, then the end result of both treatment are the same. So this is an introduction for our next lecture, is how to use all this knowledge to formulate a treatment plan. So you need first to look at the facial profile of the patient, and here what we should consider is a facial profile. This is the important one now. And then we need to consider the biology, that, for example, if any tooth movement that you are doing to improve the patient profile will not result in a periodontal damage. And then you need to consider the stability, all right? We know that there's no treatment that is stable. We have to go for retainer anyway. However, try to reduce the retention demand. Try to reduce the amount of unstable tooth movement. So your treatment plan should be an area here where you can maintain the patient's profile, maintain the biology, and try to improve stability. And this is what we discuss later in the lecture of treatment planning. That's a quick example to understand what do I mean by the paragraph before. So for example, if you see here, this patient, he's a class 2 skeletal. If you look intraorally, he has a huge overjet. There's a more premolar that is missing here. He was simply went to the orthodontist, in which he extracted one premolar, retracted these lower incisors, lost anchorage. Anyway, he has a huge overjet now. So if you look at his profile, if we decided to do extraction and retraction, we need to reduce the overjet by purely retraction of the upper incisors. Okay, wait a second here. Now, if we say that, okay, listen, extraction will not result in dishing in of the profile, I will say, oh, wait a second. That we said depends on the initial position of the incisors, that depends on the type of the soft tissue. Thinner soft tissue will react more to the amount of the retraction. And here, we have a thin soft tissue. If I do retraction, I am expecting that this patient will have a dished in profile. Although we said before that in general, there is no link between the retraction of the upper incisor and the profile, but again, we said that this depends on the thickness of the soft tissue as well. So here, if I go and extract and retract, what I'm going to do for this patient is dishing in his profile. Or what I can do is to do proclination of the lower incisors using a lot of class 2 elastics. However, when I do that, I have to make sure that when I do proclination, I will not result in any gum recession. And I know that this proclination needs a permanent retention for stability reason, which I'm going to do anyway, regardless if I'm proclining or extraction or not, because my stability is a multifactorial thing. I just need to make sure that he has enough thickness of the soft tissue, of the attached mucosa. He does not brush his teeth with force. He have a good plaque control. And this is how he finished. The profile now is at least improved or maintained. You did not retract these upper incisors posteriorly. For the next lecture, we will implement all these information and how to do a treatment planning. Thank you for listening.